Ngā mihi nui kia koutou. Kia ora, I'm Susan Reid, and I thought we'd start tonight with a karakia. Kia whakapapa pounamu te moana, hei huarahi mā tātou i te rangi nei. Araha atu, araha mai, tātou i a tātou katoa, hui e, taiki e. Kia ora and welcome to this webinar about patients with weight loss goals. I'm Susan Reid. I'm one of I'm from Health Literacy NZ, one of the providers for health coaches in New Zealand who are part of the integrated primary mental health and addiction services initiative that's being rolled out by the Ministry of Health and collaboratives throughout Aotearoa. It's my pleasure and privilege to introduce Dr. Hayden McRobbie this evening. Hayden and I worked together, it's a few years ago now, Hayden, at Counties MICO when I was providing workforce training for primary care in counties around the Raising Healthy Kids initiative. So I'll read Hayden's very impressive bio. So Hayden's actually a professor. He's a consultant in lifestyle medicine at Lakes District Health Board with a specialist interest in addiction, obesity and child wellbeing. He's also based one day a week at Te Ora, where he works alongside the Stop Smoking service. Hayden graduated with his medical degree from the University of Otago in 1996. He has a doctorate from the University of London in 2008 and has worked in the field of behavioural medicine for over 20 years. He's a professor in public health interventions at Queen Mary University of London and at the National Drug and Alcohol Research Centre at the University of New South Wales. He's also a fellow of the Australasian Society for Lifestyle Medicine, and in the last decade, Hayden has played a key role in tobacco control in New Zealand and has acted as the clinical champion for child obesity, or in child obesity, and for the New Zealand Ministry of Health. Hayden moved to Rotorua in 2019, and his current work at Lakes DHB includes prevention and management of long-term conditions and child wellbeing with a particular focus on improving outcomes for Māori. Kia ora, Hayden.
Kia ora, tēnā koutou katoa, ngā mihi nui kia koutou katoa. Thank you so much for having me. And I've got a little bit to talk through. So we'll if that's okay, get straight into it. I've titled this Conversations About Healthy Weight. But I'm going to talk just a little bit more towards the end about steps that we might take for weight management. But here's the general overview of what I'm going to try and get through and hopefully fill maybe a few gaps in knowledge. But I want to acknowledge first off that I know you've all been working in this field for some time and know a lot about this. So I really apologise if there are some things that I'm covering that you already know. So bear with me through those. So I'm going to start off with what is a healthy weight, just cover some of the statistics about unhealthy weight in Aotearoa, look at the determinants of body weight, changing health behaviours, and then focus more on the steps for weight management, and in particular dietary approaches. And I'm going to just talk about this a little bit because I hear all these sorts of things out there, this way is the best way, or this approach is better. I'm not quite sure that we've got absolutely the perfect approach for this. So, my take on this at the moment, and it's just my view, is that there are different approaches, and we've got to try and make these different approaches available to different people so they can find something that works for them. I also want to touch on behavioural support and just present a little bit of data there. What I'm not going to talk about are medications for weight management, and there are a handful of these out there, and I think we might see more sort of appear and being used as we move through these next few years. And I'm also not going to talk about bariatric surgery, which is still, well, let's face it, still the most effective treatment for weight management. Okay, healthy weight. Well, what is a healthy weight depends on who you're seeing. I know you as health coaches don't see children, but you might see parents of children, and often in whānau, if parents have an unhealthy weight, there's a high chance their kids might be of an unhealthy weight. You know that in adults we really focus on BMI, and that healthy weight range is somewhere between 18 and 25. When you get 25 to 30, you're getting into that overweight range, and then over 30 into what's termed obesity. I tend to sort of talk mostly about being of an unhealthy weight as opposed to being obese. There's a lot of negative connotations around it, and I think when you're having these conversations, sometimes it can be better just to talk about moving to a healthy weight. But you'll see as through this presentation, there'll be a few references to obesity, mainly because that's what the literature talks about. The Ministry of Health, and I'm sure you know this, have a really great weight calculator. BMI calculator. So no matter whether you're an adult or a child, it will tell you what range you're in, and also give some tips and techniques for what you might like to do. For children, just to remember that to determine whether they're of a healthy weight or not, there needs to be the age and sex-specific growth charts to determine that. And it's BMI centiles are used here to determine that. I've just got the cutoffs. Now, first off, to start, because this is often a question I get from my patients, and you probably hear the same, oh yes, but BMI is not a great indicator, and it's not. It's just an indicator of risk. That is, we know from the data that the higher the BMI, the greater the health risks. But it doesn't distinguish between lean and fat mass. It doesn't account for ethnic differences. So some of the Pacific populations, of course, have different genetic makeups, so might have more lean mass than other populations. It only gives an indication. So just bear that in mind. And there are some other things that you might like to consider measuring. So waist circumference adds just a little bit more to this. So bear it in mind, just an indicator of health risk, but not, this is where we've got to be careful with BMI and BMI cutoffs. You can move down from a BMI of 45 to 30, to 45 to 40, but still have significant risk. Now, why is this all important? Well, what we're battling with in the health system are long-term conditions, or sometimes you'll hear these referred to as non-communicable diseases. So these are things like chronic obstructive pulmonary disease, diabetes, cancer, and of course, heart disease. And the risk factors for these, well, they're all pretty similar and include unhealthy eating, physical inactivity, smoking, and harmful alcohol use. And you can throw in some other drug substance misuse there as well, but generally these are the big four. Complications of obesity, well, I've really just covered some of those, I suppose, with those long-term conditions, but there are more. And I'm not going to go through all of these. And you know what? Some of your patients some of your clients may already know some of these things as well, but there's a whole range of complications that we see from this. I think diabetes, and I've highlighted that in red, is probably one of the key things that we're seeing an increase in diabetes, which very much mirrors the increase in unhealthy weight over time. But I just want to flag here in terms of BMI, being a bit overweight actually might be a little bit protective. So these were data from a meta-analysis published some years ago now, but we don't need to go into a complete panic about those in that overweight category, that is a BMI between 25 and 30. And I think what we might like to do in moving forward is talk about, weight maintenance in this group. How can we prevent BMIs going up over that 30, 35 target limit? So helping those that are overweight stay in that area and stop progressing up through to obese. Okay, some statistics from New Zealand. Here are our obesity adult obesity statistics, so this is BMI of 30 or over, remain relatively flat over the last 10 years or so, but still around a third of the adult population in New Zealand would be classified as having an unhealthy weight or a BMI over 30. You can see there that Māori and Pacific are more likely than non-Māori, non-Pacific to be in this BMI range, and Asians are slightly less likely. There's also a socioeconomic gradient here to consider as well. So the more deprived you are, or the more socioeconomically deprived you are, then the higher the chance that you'd have an unhealthy weight. And we see a very similar pattern with child obesity. These are looking at children aged between 2 and 14. And again, rates of prevalence rates relatively flat here, but still, over 10% of children would fall into that obese category. Anyway, enough of all of the doom and gloom. What determines our body weight? I really want to flag here a couple of things. Now, some of it's going to be genetic, and we can't change our genes. We also can't change our age, and as we get older, we tend to put on more weight, as many of you will know, myself included. It becomes harder to keep at a healthy weight. It certainly involves a lot more determination to eat healthy food and not eat so much. But environment plays a major role here. And I think we've moved along a little bit from saying, well, it's just because you eat too much and you don't exercise enough. The environmental factors, play a huge influence on all of this. And even if you look at your workplaces, or if you look at, how people travel around, we do a lot less physical activity, plus a lot of the food that we do get are very calorie dense and in large amounts. So, unrestricted access to food advertising, food additives, the quality of the food, all have a role to play here. So it's not just simple. When I was going through medical school, and as doctors, we get pretty poor training in anything to do with lifestyle. But for me, I remember energy in versus energy out, and it was as simple as that. And I guess my key point here, it's not just as simple as that. And I think you've really got to focus on people's lived realities here. And you see this, if you're just looking at a change in the BMI distribution over time. This is how it would have been, back in the 70s and the 80s. So mostly in this sort of healthy range. But then over time, you're seeing it spreading out a lot more. So you see the shifting. I hope you can see the shifting in that distribution over time. Now, changing health behaviours. You're health coaches. You know how difficult this can be, right? And some behaviours are perhaps a little bit easier to change than others. But let's face it, giving up something that's pleasurable can be really, really difficult. And, it's not as easy as the sign might suggest. Substitute your yummy fish and chips for a delicious salad. How great does that sound? Changing routines are also difficult. And especially if you've got some addiction in there as well. And whilst we're not saying that food addiction is the same as heroin addiction, it's a very similar thing in trying to change behaviours that have been in place for a long time. And added to that, you've got motivation that might go up and down. And if you're trying to change health behaviours, it's always good to do it if there's a little bit of motivation change at that time. And often seeing your GP, well, depending on how your GP or practice nurse sort of sells it, but hopefully doing a good job will increase that motivation. And there's actually a bit of data about how often people are making quit attempts. There's my smoking stuff coming through, weight loss attempts. And it's just looking at this review earlier this week. which looked at a whole range of studies. But this is looking at sort of lifetime weight control attempts in the population. But there you can see the range. That almost 40 to 80% of the population had made some sort of weight loss or weight control maintenance attempt in their lifetime, and it had increased over time. No surprise there. Back in the 70s, around 20%, 18.6% of the population were making an attempt to do something, but by the time we get into the 2000 to 2010, it's close to half. So no surprise there. And perhaps no surprise either, there's some differences by geographical location. So studies from Africa showed the population were less likely to make a weight control attempt than those studies from North America. And in terms of what people are trying, well, a whole range of different things. And here I've just listed some of the strategies that people try and the prevalence. So that's how likely the population is to try each of these. So you can see here, eating more fruit and vegetables is one of the most popular strategies to try to make some weight change or improve, healthy nutrition. I suppose that's one of those key messages that has really got out there. And I think, even if you're speaking to people about how many servings of fruit and vegetables should they eat a day, many will know, yes, I should be doing about 5. Physical activity, also quite popular. But as you know, physical activity on its own doesn't make huge differences in weight management. It's, of course, extremely important in its own right. And there are numerous health benefits of physical activity, but really needs to be combined with changes in diet. There's different techniques in terms of regulating either restrictions or rule setting. So restrictions, you just eat less fat or don't eat sugar. Rule settings would be, I will only eat off this plate, a smaller plate to reduce portion sizes. Self-monitoring, self-weighing is the most commonly reported there. But then if you look down at support, and we know that support from a health coach or a health professional or from a weight management program is more likely in general to help you stick to what you're trying to change, but few people actually get to use those. So 6% in this meta-analysis there. In fact, you're more likely to buy vitamins for weight loss. So something perhaps we could work on. Now, taking action then. Just starting off with brief interventions. Now, you might know all the brief interventions for smoking cessation, for changing alcohol consumption. And indeed, there are some data that suggest that it can also help motivate a weight loss attempt. So healthcare professional advice to do something about weight or healthy eating was associated with people then wanting to weigh less and attempting to make a weight loss attempt. Okay, so brief advice does prompt people to change, or at least to try and change their behaviour, coming out thinking, yes, I'm definitely going to go and do this. But that's where we need to join them up with, what we're doing. Now, this study was published in The Lancet about 4 years ago now, but this is from Paul Aveyard, who has done a lot of work in the brief advice smoking field. And he thought, well, could we do the same sort of thing with GPs providing support to help people lose weight? And so he did this in a randomized controlled trial, and the intervention group, the GP there said, right, I'd like to help you quit smoking, and this is what I've got available. I can refer you to a weight management group. And actually, most of those patients in that arm agreed to go and attend. Now, of course, in front of your doctor saying, yeah, I'll go, doesn't mean that they all will go. So 40% of that population actually did attend, and their mean weight loss at a year was almost 2.5 kilograms. The control group, the GP just said, hey, look, you'd really benefit from weight loss. Good luck, get out there and give it a go. Now, 9% of people found their way to a weight management group. Now, in the UK, there are a number of interventions available to the public and funded, so there are things there that people can do. But the mean weight change in that group overall was 1 kilogram. So the difference there, 1.43 kilograms, not quite statistically significant, but you get the general idea. If your doctor or nurse or health professional does this in a nice, kind, caring, respectful way and offers support, then people do accept that. And I think that's where you can see that rolled into the sort of health coaching role as well. And maybe some of our colleagues still need some support in having these conversations. And Susan and I talked a lot about this when we were talking about child wellbeing and child obesity in particular. We really need to have these conversations that are positive and non-judgmental. And a lot of people who are of an unhealthy weight, it's not their fault. And I think it's important to realise that we're not there pointing the finger, but we're there supporting them to make positive change. And there's a whole lot of ways that you can do this, and many of you will have your own style. And I probably, in all fairness, use a combination of a whole lot of different approaches. A little bit of motivational interviewing, a little bit of acceptance and commitment therapy. But here's some examples here of change talk, which really uses the person's own statements about what they want to do, and helps get those or use those to help change their behaviour. So those needs. I want to be a role model for my child, or the fears. I don't want to get diabetes. And you can turn that. You're listening to them make those statements, and then you can move those into the conversations where you might want them to go. I quite like the commitment language. So I think sometimes when we're talking about behaviour change, we don't often link it to the behaviour they actually want to change. So here's an example here. Next time I go to the grocery store, I won't buy junk food. It's making that commitment. If I give you an example that I might use in smoking cessation, I might say, if you get, or I get them to say it, so if you imagine I'm a smoker, if I have an urge to smoke, I will first chew on a piece of nicotine gum before I have a cigarette. So it's very sort of structured and planned and not all woolly. So people know when they go away what they're going to do. So next time that I really feel like opening a packet of crisps, I will instead first go and take a carrot out of the fridge and peel that and try that first. So it's quite sort of structured tasks. And of course, you have to agree this with people, because if you just say, I want you to do this, it may not apply to them. So, trying to understand what they might be able to do is really important, and then put that into a little bit of commitment language. Motivational interviewing, consistent communication here. Now, as I say, I don't use motivational interviewing all of the time or exclusively, but I really like some parts of this. And things like asking permission before you just launch in with offering solutions and advice. Is it okay if I talk to you about this? Or is it okay if I explain what your healthy weight would be? Without saying, well, look, you're here and you need to be here. Of course, doesn't come across very well and unlikely to get change. Also, when you're talking to people, just picking up the positive things, reinforcing their confidence is really important. You know how difficult it is to get big change happening. And so reinforcing these little things along the way is really important. Now, some of my colleagues will say, well, yeah, that's just going to come across as patronising. I don't think that's the case at all. And people like a little bit of patting on the shoulder, every now and then. And it's really about acknowledging that the positive steps that they're taking. I think too, this when we're talking about changing behaviour, often we're talking about regaining control. And trying to get across that you've got some choice here. And I think this is where it's useful when we're talking about different approaches to this. You can let people choose, as opposed to dictating exactly what they should do. So having conversations that emphasise a little bit of control. Using open-ended questions, I don't think I need to go into that because I think you're all really good at that. But then, of course, and especially in follow-up, these reflections and reframing is useful when people have come up with barriers or things didn't work out for them. It's useful to move back and reflect about what, maybe what went wrong, what they could do differently. And making sure, I've highlighted this in bold, statements that convey genuine support or understanding. So there's not making it up, but really showing some empathy that people are trying, and it can be difficult sometimes. Okay, so what else is around to help us? Well, we do have guidelines. I'm not going to focus too much on weight management in young people and children, but there are some guidelines for this. You can just Google weight management children and NZ, and it will come up with what we need to do. For adults, I was involved in writing these, but oh my goodness, they're 2011. So they're kind of getting a little bit out of date here, but kind of still, the key concepts are still correct. And I'll go on to these in a little bit more detail in a minute. But the 4 steps. So the first one is monitor. If you don't measure growth in children or weigh adults, then you can't even start that conversation. Well, you might be able to actually. There might be, it might sort of come up, or people, it might be clearly obvious. But I think, we've sort of shied away a little bit, perhaps, of regular monitoring of growth, and especially regular weighing in adults. But I think it can be done in a way which is not threatening, and again, that you're not judging. And letting people just tell you what their weight is often a terrible idea, because often people underestimate what they actually weigh. So usually when I'm at my GP, I just go and find the scales, pull them out and jump on top of it and make sure they update my record, because otherwise, how do you know how I'm going? Now, the assessment, I don't think you need to know about this in any detail, but I guess just to know what might be done in a full assessment of an unhealthy weight. And it's slightly different for children than it is for adults, but there's an examination part to it as well. Obviously, weight, height, waist circumference in adults, and blood pressure. So just to know there are some things here. In adults, of course, you want to know about what they're eating, physical activity, sleep's important, I'll come on to that. Medications they might be using. Certainly some of the medicines that we use in helping people with mental illness can contribute to weight gain. So can some of the oral contraceptive medicines as well. So, just teasing out those things is really important. Family history of obesity, family history of heart disease, again, and weight loss history. And you'll know as well as I do that when you start talking about these things, people will often come up with a whole range of things that they've tried, and they've yo-yoed, and they've gone back and they've tried the meat diet and the Atkins diet and the bread diet, and the list goes on. Now, in terms of management, this is exactly the same for adults as it is for children. And these behavioural strategies are really pivotal, and you can do something in this space, which is great. And it's FAB. It's FAB, food, activity and sleep, and behavioural strategies to help cement those in place. So these are the sort of 3 4 areas, if you're including sleep as a separate one, to throw in there and see if you can help make some change with. So food, activity and sleep, and behavioural support. For kids, it's not about weight loss in kids here, making that really clear. It's actually around big changes within whānau. So if you can change the eating and activity and all these behaviours for the family, then the kids just will naturally benefit. For kids, often see portion sizes that are adult portion sizes. Obviously, sweet treats and crisps and all sorts of things that kids will eat if you let them. So just making those sort of changes can be really important. That sleep time is really key, I think, especially for kids. And getting enough sleep is important. So, these guidelines are online, so look them up. But people are often surprised when I say, well, your toddler or your preschooler should still be getting somewhere between 10 and 13 hours of sleep a day. And, how many preschoolers do you come across that are sleeping 8 hours? Probably quite a few these days. So getting the right amount of sleep is really, really important. For adults, and I'll come on to diet changes in a minute, but I think it's probably more about stickability, about choosing something that you can implement and sustain. And my personal view here is that, if one approach doesn't succeed, what else can you try? And there's lots of different ways of doing this. We've got to talk about exercise. As I mentioned at the very beginning, exercise doesn't have a huge impact on weight loss, but it has so many other health benefits. And if you're not the expert in physical activity, there's Green Prescription, and they're really great at getting across and getting people active and out there. So, make sure that's part of the whole approach there. And sleep, and I'll come on to sleep in a minute. Now, setting goals, the ideal proportion of body weight to be lost is, so I was reading the other day, somewhere around 13%, and that's quite hard. So often the goals for weight loss in the first 6 months sit between 5 and 10% of your baseline body weight. Now that's, I say it's so much easier to say, isn't it? 5 to 10%, but oh my goodness, that can be pretty tough when you really think about what that means. The goals do have to be realistic, and people really sometimes do have quite unrealistic goals. And this was just an example here, an old study now, but the investigators asked 60 middle-aged women with a BMI of over 35 about what their sort of weight loss expectations were. And their dream weight loss would be 38% of baseline weight lost. That's their dream. Their disappointed weight loss, well, it's not even in our recommended weight loss thing. 17% body weight loss. Sort of people would be feeling disappointed. So that's kind of how unrealistic people can be. And then, of course, they don't achieve those goals and they feel, I failed, I can't do this, see, it's a waste of time, I might as well just keep on doing, eating more and eating poorly and not exercising because I just can't do it. So, and you might even break it down a little bit more. I like to say to my clients, look, aim for 0.5 kilogram a week. And just take it at a really small approach. Now, if people say, well, I really would like to go for 1 kilogram weight loss a week, I wouldn't say, no, don't be stupid, you can't possibly do that either. So it's finding that right balance with all of that. Now, in terms of food, and now this is where, there's a whole lot of variations in what you might do. And I'm not going to get into which the best dietary approach is or not. But in general, and I think this is true, that a healthy diet has a high consumption in general of nice, non-starchy, green leafy vegetables. And we know that green leafy vegetables, for example, have a really good benefit for cardiovascular risk reduction. Whole fruits, not put in a smoothie or juice. Berries are good, as you might know. We know that greater than 3 servings a week is associated with some positive changes for cardiovascular disease. Whole grains and legumes. So your beans are a good thing here. Moderate, less or moderate consumption of these other things such as nuts and seafood and lean meats, and then really limit the consumption of sugary snacks and especially sugar-sweetened beverages, because that's something that people forget about as containing calories and sugar. So water's best there. Now that's kind of the ideal. But a lot of the people that we might be seeing are not in that ideal space. And so a different dietary approach, I think, is often needed to sort of get people kick-started to lose the weight they need to do. So, this is probably the goal. This is kind of the goal to get to when you're there and you're starting to head towards a good, healthy weight, and certainly for maintenance. But I just want to go through some of the different dietary approaches that people can take and where the evidence is behind these. And just bear in mind that these are summaries, and to go into the absolute detail would take a little bit longer, but always happy to have conversations at a later date. So in terms of reducing calories, there are kind of a few different ways of doing this, but in general, it could be every day you're reducing your energy intake, and typically this is by 500 to 700 calories per day. I'm sorry, you'll have to bear with. I just can't get myself working in kilojoules, so it's all calories here, I'm afraid. But so for women to get this sort of weight loss, you're looking at somewhere between 12 and 1,500 calories a day, and a little bit higher for men. It often involves counting calories, although that's changed a little bit with some of the sort of pre-made meals or food bags and things like that can make this a bit easier. But this constant energy restriction is also quite difficult to sustain for some. So another approach would be just to really restrict your energy intake on just some days of the week. And there are different, range of different options here as well. Time-restricted eating, I suppose, would fit into a continuous energy restriction, because it would be every day, but I'll come on to that. I'll cover that in just a minute. But one of the most popular sort of intermittent energy restriction diets is the so-called 5-2 diet, where people simply restrict their calorie intake on 2 days of the week. And this is typically non-consecutive days. I remember trying this when I was in the UK, probably about 10 years ago, when we were looking at different weight management programs. I found this pretty hard, I must say. But 2 days of the week, you really severely restrict your energy intake. But on the other days of the week, there's no formal restrictions. So as long as you're sensible, you can kind of eat what you like. And this does have some benefits and does work for some people. But like everything else, it's the sustainability of it all. Now, there are very few randomized controlled trials that look at these approaches. So more research is needed, especially for that 5-2. I mentioned time-restricted eating. So that's really just eating within, for example, an 8-hour period. And typically that also reduces your overall energy or calorie intake for the day. Now, diets. What diets work? Well, I guess the bottom line is that most of these different diets work. Now, this is essentially a results from a meta-analysis, and you can see a whole lot of different studies here. But if you just look at down here, you've got these different diets: Mediterranean Atkins diet, paleo diet, zone diet, all very similar. And this is looking at weight change. So on this side of the dotted line, that means weight loss. And you've got the average weight loss with the range, typically the 95% confidence interval around that, and weight loss mostly at a year. And you can see all of them here sit on that left-hand side. So they can all help people lose weight even longer term, okay? So you've got these different Atkins studies here, which is essentially a low-carb diet, Mediterranean diet, which is sort of a healthier, perhaps, sort of version, lots of grains and beans and things like that. But you can see that these diets can and do work. Just to illustrate these different approaches, this was a trial in the UK, and they took over 700 obese and overweight adults, and they randomly allocated them to one of 8 interventions. And some of them were commercial programs like Weight Watchers, Slimming World. Some was just counselling and general practice. Some of it was counselling in a pharmacy. One group got to choose one of 6, and the control group were exercise vouchers. So they had vouchers to go and do the exercise. And this was weight loss, you can see here, in kilograms at both 12 weeks and at 52 weeks. Now, at 1 year, at 52 weeks, the only program that achieved significant weight loss compared with the control group was Weight Watchers. Okay, so those that were allocated to Weight Watchers had significantly greater weight loss than the control group. But even the other ones still lost weight over time, okay, just not significantly more than the control group. Now, the low carbohydrate diet, I think, is probably the one that comes up a lot. So low carbohydrate, the Atkins diet restricted carbohydrates to less than 30 grams a day. In general, that's for me, that's kind of tough, but certainly not impossible, and people get used to this over time. I think the long-term compliance, though, and this is what you see all the time to these really low carbohydrate diets, can be difficult. There have also been some concerns raised about the fact that they're or can be really low in fibre and high in saturated fat intake, but I don't think it needs to be that way. I think you can, use these ketogenic diets, these really low carbohydrate diets, in a way where you are getting some fibre in there as well. And when I look at all the evidence, overall, these really low carbohydrate ketogenic diets are more effective, at least in the short term, than some of the other dietary strategies in terms of weight loss and improving some of the metabolic variables in patients with diabetes. So I think this is why you hear people are often really keen on these diets and people with diabetes. But there's some pros and cons to all of this, as with everything. And coming back to one of my original points, which was, hey, look, this might just be a way to get started and a way to get into some weight loss and making some improvements and making some gains, but moving people on to a more varied diet over time. And just to show you, here's a trial where they randomized people to the low-fat diet, a Mediterranean diet, or a low-carbohydrate diet. Now, in this study, the low-carbohydrate diet was 20 grams of carbohydrate per day, but only for the first 2 months. Then they slowly moved up to 120 grams per day, which was much more bearable, I think. But that's really the only restriction they had. They didn't have any calorie restrictions. They could essentially eat as many calories as they liked, but it was that really low carbohydrate diet. They were also given some advice that actually, choose the vegetarian sources of fat and protein, and avoid some of the trans fats. So, olive oil and things like that for that vegetarian source. Mediterranean diet, really rich in vegetables, low in red meat, poultry and fish in there. They did have calorie restrictions in this diet as well, and it was the same for the low fat. So for men, 1,800 calories a day, and for women, 1,500. And these were the results over time. So this is up to 2 years. And you can see here's the low carbohydrate diet. Very similar actually in terms of outcomes to the Mediterranean diet. But what's this? Around about 5 kilograms of weight loss over a 2-year period. So really good. But look, you'll notice this, and you see this with Atkins diet as well, really quite rapid weight loss quite quickly. You see there at 5 months, this low carbohydrate diet, over 6 kilograms on average weight loss. Just some notes about diet. With the Mediterranean diet in that previous study I just showed you, it was really the increase in intake of vegetables and a reduced intake of sweets and cakes that predicted the weight loss. So just switching around to eating many more vegetables, those non-starchy or low-starch vegetables, and cutting out the sweets and the cakes, maybe for some people that's really all that needs to be done. And we also know from other data that sticking with this diet can really, is associated with people living longer. There are other things like these high protein diets. My patients last week said, I want to try the meat diet, which I'd never heard of before, but I guess that would fall into that technically a high protein diet. And some people say, well, they work because protein's better at satiating your appetite, and it might preserve some of your lean body mass so you don't lose the muscles. And finally, formula diets on here, they can work really quickly as well. They're often called very low-calorie diets because they have next to no calories in them. And they can, again, work quickly. Often need to be a little bit careful with some of these and need to use it under medical supervision. Now, something else that often comes up is it all just about the quantity of the food you eat, or is it quality as well? And I really like this statement. This is in one of these reviews, that the ideal diet for treatment of overweight and obesity is defined as being safe, efficacious, healthy, nutritionally adequate, culturally acceptable, and economically affordable. And I think that's true, actually. You have to kind of cover all of those things to really get something to work for people. And this is where these conversations are really, really important. I know that economically affordable can be tough sometimes, but I think it's achievable. It just takes a lot more effort and knowledge to do that. Sleep. Yeah, I'm going to mention sleep because it's really important. You know it's important for kids, it's important for adults as well. And we know that reduced sleep duration is associated with an increased risk of obesity, but also having a consistent sleep going to bed time might be important as well. So getting your body trained that, it's, if you're like me, it's 9:30, off to bed. It doesn't matter as long as it's consistent and that you're getting, at least 7 hours sleep a night. For most people on average is what you need to do. So the data here from the Nurses' Health Study, those that slept 5 or less hours a night were 15% more likely to be obese than those that got more sleep. Now, just to finish off, behavioural support. And I guess this is one of my areas of interest in particular, is how do we better support people in the long term to stick to what they're doing? This particular study that I led in the UK a few years ago now, but this was something we developed following on from, actually I got into this whole area because people who smoke gained weight when they quit, and they're coming back to me saying, well, I've quit smoking now, but now I've put on several pounds. So we were looking at how we best help people achieve longer term weight loss. And in the end, we sort of decided that actually giving people a whole range of different options and then just helping them stick to what they chose and weighing them on a regular basis might be worth testing. And that's essentially what we did. And this was a group-based intervention. So they had 8 weekly group sessions. I like groups, like group treatment because it's a lot less work for me. And people tend to share their ideas and achievements. and work together to do it. The control group was nurse-led, 4 sessions over 8 weeks, and they just talked about the general portion sizes, reduced sugar-sweetened beverages, etc., etc. And at a year, the group intervention had just over a 4 kilogram weight loss, roughly double that of the nurses, and that was just a significant difference there. But that nurse intervention still worked. Not perfect. I think I'd continue to modify this, but more recently, you stick more intensive support and you get even better results. So this was, again, a general practice-led intervention. It was essentially health coaches doing the behavioural support, and they randomised people to either this intensive lifestyle intervention or usual care. Now, it was intensive. 22 weekly sessions, 16 face-to-face, 6 phone calls in the first 6 months. Most were one-on-one, but they did do some small groups where they were able, and the goal was 10% loss in body weight. Also encourage physical activity. The focus changed as they went through. So initially it was focused on portion control foods. So by that I mean, a banana, as opposed to stuff that you might pour out of a packet and have no idea where that, how much you've actually eaten, or prepackaged foods or meal replacement shakes, that sort of stuff. And then it moved into instruction on how to purchase, prepare, and manage portion sizes and energy intake. So it started off by saying, well, let's just keep it simple and you just do this, this, and this. But over time, how can we do things a little bit differently and prepare yourself to manage it all yourself? They also provided electronic scales, so people weighed themselves and the data was entered straight into the system. And here you go, 1 year weight loss, really, really good, over 7 kilograms in that lifestyle intervention group. And even out to 2 years, there was still quite significant weight loss. Not quite the 10% that they might have wanted to see for that length of time, but that people's weight fluctuates over time. So I think this was pretty good, but very intensive. Last step, maintenance. I guess this is perhaps one of the hardest things. And I know lots of people, go back and they gain weight again. And I think this is where we have a really important role, just to keep encouraging people to give it a go. And to do that, we do need to measure how they're going, which does mean weighing, at least occasionally. And I think accept the setbacks. This is a tough thing to do, especially in the face of environments which are not supportive to healthy weight. But what can they do as a whānau? What can you do with events such as iron moulding, community gardens, and really trying to look at these different approaches to help support people maintain their behaviour change. And just to summarise in a few, I guess, final words, there's a whole lot of ways to do this, to achieve a healthy weight. And I think most of your clients/patients will know at least some of these. And most people of an unhealthy weight have probably tried to lose weight multiple times even, and may have been successful in the short term, but have sort of stumbled and regained a lot of that weight. I think there are a range of quite sensible strategies for weight loss. You don't want to be telling people to take up vaping, for example, to help them lose weight. But you do want to be able to provide people with a range of options and enable them to choose what might be best for them. Sometimes there might be a little bit of direction based on what's worked for them before, or perhaps their comorbidities. But a key part of what you're going to be doing, and certainly what I try and do in my practice, is support people to reach their goals. So this is never one-off. It's always touching base with them, being kind, having a good attitude, as the sign says. And, if they first don't succeed, try and try and try again. I know it's a tough road, but the work that you're doing is really important. And so, stick with it and learn from people as we go through. I think that would be really nice to share. So I'll finish with that. Thanks very much.
Kia ora, Hayden, thank you. We've just got time for a couple of questions. So we've got a question from Kate Broderick, and she said, what evidence is there for the timing of the main meal? Should it be at midday or in the evening? Is there any evidence around that?
That's a really good question. As far as I know, no, there's not a great lot of evidence around that. One of the bits of information that has more evidence is breakfast. Like, so people often say you must have breakfast. Actually, the evidence suggests that it doesn't matter if you have breakfast or not have breakfast. It ends up being how much you're eating over that day. I mean, eating just before you go to bed, that's often associated with, gastroesophageal reflux, and then you feel bad and people get up and want to, eat more to solve those. So it's about trying to tackle all of those things on an individual basis as well.
I just want to check, because you and I have had this conversation. So for children, is breakfast still important for them?
Look, I think children learn better when they've got something in their puku. For them and the concentration, yeah, absolutely. I think that's often good habits too in getting into breakfast. But for adults, it doesn't seem to be so important.
The other question there is here from Rebecca Short, and Rebecca said she said the data you showed about sleep and weight gain was a study relating to women. Is it the same for men as well?
We make the assumptions that it's the same for men. There are some data in the general population, so not just for women, but that nurses study was a really large study, so it gives us we can be quite confident. Nothing's ever 100%, but we can be quite confident that sleep's important, and getting enough sleep, but also having going to bed at a very similar time.
And there's one more question, if it's okay. So Kate asked this question right at the beginning, and you made the comment about the impact of some drugs and medications that people have to take if they've got mental health conditions. And if we flip it the other way, what's the impact of being an unhealthy weight on people's mental well-being?
Yeah, well, there's so many things that we neglect in people with mental illness. We often think that their physical health is the least of their worries, but we've got some reasonable evidence that having a good, nutritious diet also helps with mood and functioning, and so this is equally as important.
Cool. Thank you so much. Thank you so much for coming and sharing with us, Hayden. It's been a pleasure to work with you again, albeit very briefly. And thank you so much for all the participants we've had this evening and the fantastic questions we've had, and for being here. And we've had a number of comments saying this has been a fabulous conversation. It's been gold, with a comment from some person. So thank you. So before we go, I'll just close with a karakia. Ka whakaria te tapu, kia wātea ai te ara, kia tūruki whakataha ai, ku tūruki whakataha ai, hui e tau ki e. Kia ora everyone, have a lovely evening.